I'm Lisa Voltarelli. I'm going to be talking about buprenorphine, office-based updates, and evidence-based updates. So my goals today are to review some of the trends in buprenorphine prescribing in primary care, to review the current standards in office-based buprenorphine care, including treatment initiation, dosing, and urine drug testing, and then briefly review some alternate forms of buprenorphine administration. So just some brief background. We love buprenorphine, and part of the reason is because it has really good evidence for actually people that are initiating on treatment, decreases risk of overdose deaths, and has pretty good treatment retention. So kind of some of the background that we've already talked about this morning. It's a partial mu agonist, so it has less risk of overdose. It has very high receptor affinity, so it can precipitate withdrawal, which we'll hear much more about a little bit later this morning. It has a long half-life. It has really great efficacy, certainly superior to placebo, but still in most evidence secondary to methadone. We can prescribe it in an office-based setting, so outside of a standard like opiate treatment program for providers that have a waiver, as we heard about earlier. And it's typically formulated with naloxone to prevent misuse and overdose from potential like injection use. So I would like to review some of the prescribing trends. So basically, buprenorphine is being prescribed more and more. This is kind of looking at, this is based on pharmacy claims in the US from 2010 to 2018. And it's really primary care providers that are the ones that are responsible for the dramatic increase in how many patients are accessing buprenorphine over the last several years. And so I think this is really powerful to think of primary care docs being the primary people that are delivering buprenorphine care, and that's going to continue in that direction in the coming years. So let's talk a little bit about treatment initiation and how we're delivering care for people that are wanting to initiate buprenorphine. So I just kind of want to review the kind of standard model with which we normally initiate buprenorphine care in an office-based setting. So this is the Massachusetts model, is kind of widely used, started in the 2000s, endorsed by SAMHSA, and has allowed buprenorphine care to spread across many primary care sites across the US. And their model for initiation is there's a phone, someone expresses interest, they do a phone intake interview with a staff person where they get some history and talk about maybe their treatment goals. And then there's an in-person nurse intake in which they do more history, some addiction education, get labs drawn for infectious disease type things. And then a provider intake in which the diagnosis is confirmed, and a physical exam and some more history. And then on that fourth touch point is when they actually get a prescription. And so one can imagine that there are a lot of barriers to this kind of traditional model of initiating buprenorphine care in an office-based setting. So there was one study that was kind of looking at what happens. So between the time that people are seeking treatment and actually engaged in treatment, what happens. And so this was a local study done at Harborview Adult Medicine Clinic, office-based setting, had 100 participants. And they looked at that exact question. So you can see they use the Massachusetts model. And so between the people that completed the intake interview, there were about 100, only 40 ended up being induced on buprenorphine. And so that's a 60% dropout, which is really high, probably higher than many of us might think. And I don't know that we still have a full understanding of exactly why this is. Certainly lots of barriers with multiple visits. And they looked at kind of their analysis showed that people that had been in prior treatment before, so prior methadone or buprenorphine care, had a decreased rate of actually proceeding with induction, and polysubstance use was actually a really strong predictor of dropout. And the thinking was that in part, people with polysubstance use are at higher risk, but their program this model kind of discouraged people with polysubstance use from going on to completing care with them. And so based on these findings, they actually removed that from their kind of protocol to allow more access. But the main takeaway from this is we can see that there's a lot of barriers of people interested in care that end up not quite making it. So then what about dosing? How does our initial dose that we give to someone at the first time they come to us for buprenorphine care, how does that impact their whether they go on to succeed in treatment? So this was a large multi-site study looking at Medicaid insurance claims with about 17,000 participants, adults in the US. And the primary outcome was discontinuation at 6 months. And the strongest predictor, this was a high-powered study, they were able to look at lots of kind of social and demographic factors. And the strongest risk factor for discontinuation at 6 months was an initial dose of less than or equal to 4 milligrams a day. And you can see that the really steep part of this curve is in the beginning. So the first 30-day dropout was really quite high, suggesting that maybe this was a failure, not of maintenance, but more of treatment initiation. There was another very similarly designed study looking at insurance claims for commercial insurance, and had a similar number of participants, around 17,000, and it basically saw the same thing. So that it was kind of the same thing was borne out in a commercially insured population, that initial dose less than 4 milligrams a day was a strong predictor of treatment discontinuation. This study went on to also kind of look at prescribing patterns. As far as like looking at what other providers are doing, so about 10% of providers are prescribing an initial dose of 0 to 4 milligrams a day. And then most people, maybe similar to what we would expect, are in this 15 to 23 milligram a day dose as what people are being initiated on. This study also looked at how many days providers are giving as a risk factor for treatment discontinuation on the initiation of treatment. And they found that fewer day supply was predictive of treatment discontinuation and predictive of increased adverse events, mainly like hospital admissions or encounters for an opiate-related or overdose type thing. So, and they also looked at prescribing patterns. And this is really, I think, really interesting and surprising data to me, showing that 33% of providers are giving a 28 or more day supply. So I don't really know what to make of this. You know, these were patients that hadn't had any claims for buprenorphine in the prior 6 months. And so maybe it's just the people that had been on buprenorphine before or who were more stable got a higher, longer day supply. And then, more probably what we would expect is about a third of prescribers were giving a 0 to 7 day prescription at initiation. And for, at least in Washington, for Medicaid, for initial prescription, we were required to give like a maximum of 7 days. That's the most we can do at an initial prescription. And I think that another kind of piece to think about for this is maybe giving people more at an initial visit and decreases barriers, including frequent visits to pharmacies, more copays, and maybe allows people more flexibility to play around with their dose as they're going through induction. So now I want to talk about dosing and what is the right dose. So the SAMHSA and ASAM guidelines, and as well as like the FDA recommend a target dose of 16 milligrams a day of buprenorphine. And there's a lot of evidence that 16 milligrams a day has pretty good retention and definitely better than placebo and definitely better than lower doses. Although we get a treatment response even at lower doses as low as 4 milligrams. And I think there is, in general, this theoretical risk of a increased risk of diversion at higher doses, although there isn't a ton of evidence to support that. So I want to look at, this was a pretty large study looking at treatment retention by dose. So this line with the triangles it's comparing to methadone. So we still see that methadone, and this line here that with the diamonds is buprenorphine. So we still see that methadone is superior at treatment retention to buprenorphine. But we can look across at different doses of the medication, and we see that there is an increase in treatment retention of around 40% at 16 to 20 milligrams and up to 60% retention at 30 to 32 milligrams. And the total for this study for buprenorphine was about 46% treatment retention. And that was completion to 6 months of treatment. And these were patients that were flexibly dosed. So thinking maybe there is a benefit. There's certainly a benefit getting up to 16 milligrams, but maybe pushing the dose higher does have some benefit. And so this was another study kind of looking at dose. This was a study of a primary care-based setting in, I believe it was in Virginia, and it had 300 participants. And basically Medicaid at some point in time imposed a 16 milligram max dose. And so there was this group of people that had this insurance coverage that had previously been on doses higher than 16 milligrams. And then we were forced to decrease their dose to 16 milligrams or less. And maybe not super surprisingly, there was an increased rate of aberrant urine drug screens from 27% to 34%, which was statistically significant. And then the group that had the other insurance, granted they were the non-Medicaid insured patients, but the group that was greater than 16 milligrams throughout had better treatment retention and decreased rates of urine drug screens throughout the entire study. So suggesting again that definitely a mandated dose decrease is not patient-centered and probably not a good treatment, but also that maybe maintaining people at slightly higher doses can increase retention and decrease use. So now I want to talk a little bit about urine drug testing. So it's kind of mainstay in our treatment for opiate use disorder, but there's really not a lot of evidence behind it. It's really consensus and expert opinion driven. And more we're being encouraged by ASAM and by SAMHSA to use it really to promote support and accountability and not to be used as a punitive metric, as a punitive means. It's about trying to make sure that we're meeting people's treatment goals. And one way to think about it is to maintain the therapeutic alliance, to remove so that the provider is not the detector and it makes the urine drug test this more objective thing, the detector in a visit. And so what are our types of urine drug tests? There's the immunoassay, which is the point of care kind of dipstick pictured here that we're all probably pretty familiar with and is used in kind of routine screening, and it's cheap and you get your results right away. And then there's definitive testing, which is GCMS, and it's a send out test. It's more expensive. It's quantitative, so you get an actual number back. And you can, it tells you definitively what is in the urine versus there can be false positives and false negatives with the immunoassay test. So one of the ways you can use this for buprenorphine is you can test the buprenorphine metabolites using GCMS. So now I want to talk a little bit about how to use this for buprenorphine testing and how to interpret it. So if someone takes a film of buprenorphine sublingually and it goes into the bloodstream, some of it makes it to the liver, and then the liver turns it into norbuprenorphine. And then the norbuprenorphine ends up in the urine. And meanwhile, some of the buprenorphine is still floating around, so that also ends up in the urine. And so how much of those things are there at any given time is really a snapshot. And it's kind of dependent on how recently they took their dose and how fast that any given individual's metabolism is. So it's up to us to kind of interpret this and figure out how we can use this. So if you get a result back for these tests, it will usually range from 0 to 1,000. Some labs have numbers greater than 1,000, but most is 0 to 1,000. And I think a really important point to know is that the levels that are found in the urine do not at all correlate with the dose. So we really can't use it in that way. The way that it's most helpful is to basically detect or see if there's like a tampered urine sample or a treatment discordant sample. So if a patient hasn't been taking their medication and has been using, they can dilute their urine sample and dip a film of buprenorphine into the urine sample. And on the immunoassay, it will come positive. But if you test it for these metabolites, it will be, you will see a very high level of buprenorphine, but minimal norbuprenorphine. And again, we want to use this really to make sure that we are aligning with someone's treatment goals and helping them in the way that in any way that we can. And there's actually been several case studies of this sort of testing being used in a compassionate way and actually helping kind of redirect and reorient and get people engaged in the treatment that they need and want in a positive way. So the way that we can interpret this then is the norbuprenorphine to bup ratio. So I will talk more about that. So it's been, this ratio has been kind of coined and described as a standard way to interpret these results. This is a graph of, you see of a group of participants that took a single dose at time 0, and you basically see the ratio increase over time. So at the very beginning, when someone first takes a dose, the ratio is very low because the amount of buprenorphine is really high and the liver hasn't had time to do its job yet. But over time, the liver metabolizes more and more, and so the ratio increases as the amount of buprenorphine decreases. But when we're seeing a patient in clinic, we're getting some snapshot in time, and the level is kind of going to go up and down based on when they took their last dose. So a patient takes a dose and the ratio is going to go down because buprenorphine goes up, and then longer time passes and then the ratio goes up again. And so we want to have a way to interpret these to say, is this a physiologic level or not? So the kind of previously kind of commonly described and probably most commonly used in clinical practice cutoff is 0.02, which is is highly specific. It's a pretty low ratio, but not as sensitive. And so there's some recent studies that have suggested a higher ratio as being more sensitive for detecting an aberrant urine drug screen of 0.2 to 0.3. But it's not clear cut, and we really can't use this diagnostically. We can use this to have an open conversation with a patient. And the main takeaways is that if the buprenorphine level is really high or the ratio is really low, that can make you think about a discordant sample. So then this is, we can kind of use what we've learned to interpret this study. So this was a study in a primary care-based buprenorphine treatment program in New York, looking at 33 previously thought to be stable patients that were transferred to a new provider based on clinic staffing changes. They had a routine new urine drug screen, and around that time, Epic happened to default to collecting bup plus metabolites. And they found that there were 27% of this small sample of 33 participants that were had treatment discordant urines, which is much higher than previously reported rates. So I think the authors were really quite surprised by this finding. But if we can look in this graph, we can here on this axis is buprenorphine, and on this axis is norbuprenorphine. And we can see that these are kind of the ones that were suspected discordant samples with the really high, so 1,000, and their lab had a cutoff of 1,000, so it was 1,000 or greater, high buprenorphine with quite low levels of norbuprenorphine. And so the current kind of standard threshold of 0.02 would have actually missed a lot of these samples versus a ratio around 0.2 would capture some of these samples. And then just kind of thinking about looking at some of these other samples. So these ones here also have really high buprenorphine levels, but also quite high urine, the norbup. So we can think, okay, maybe probably the patient is taking the medication and maybe they just took a dose or something. And then these high norbuprenorphine levels are consistent kind of with physiologic samples. So this makes us think that maybe more metabolite testing kind of in a routine basis might yield some more information in an office-based buprenorphine setting. So kind of in summary for metabolite testing and urine drug testing. So in general, urine drug testing, even the kind of presumptive immunoassay testing, it's not really evidence-based, but it's thought to be a way to kind of have objective data to see if we're meeting a patient's treatment goals. It's not diagnostic, and it really has to be interpreted within a clinical context, but it can help see that we're helping our patients in the way that they're wanting. So quickly, I want to talk about some other methods of buprenorphine administration. We've been talking about in the kind of common standard buprenorphine is like Suboxone, it's sublingual, taken once or sometimes more times per day. Sublocade is a subcutaneous long-acting injectable medication. It's administered with monthly injections, and you can see this illustration here. There's basically an injection of the medication subcutaneously, and over the course of a month, it kind of slowly seeps out and creates a sort of steady state of medication. And it's administered with an initial loading dose of 300 and then going to 100 milligrams monthly. It has to be administered in an office, like in-office setting. It can't be given to patients to take home. There's definitely a risk if this were to be injected intravenously. It's a high dose. It could be dangerous. And interestingly, this has only been compared in only been studied in placebo-controlled studies. So it actually hasn't been compared head-to-head to like sublingual buprenorphine. And it isn't FDA approved for induction. It's meant to be initiated 7 days after being stabilized on submucosal. And then there's this other one, CAM 2038, which is approved in Europe, but not yet in the US. And then the implant, Probuphine, it has a 6-month duration. It's 4 implants that are implanted under the skin at once. It has to be 4 to be effective. So a little bit more involved than like a Nexplanon insertion that we're familiar with. It has been compared in trials against sublingual buprenorphine, and it was effective for patients, like equivalent to patients that were on 8 milligrams of sublingual buprenorphine, but not necessarily. People that were on higher doses had an increased rate of dropout. And so it can be implanted and left in one arm for 6 months, and then it's removed. And then you can put it back in you can put a new one in another arm for 6 months. But then after that, there's no approval for like ongoing treatment because it hasn't been studied in like being replaced in like previous scar tissue, and it hasn't been studied in other like parts of the body. So some limitations, but definitely can be good for kind of having something that's a little bit more long-term than a daily medication. Yeah, so in summary, we talked about a lot of things this morning. Most importantly, I think, is that primary care is buprenorphine care, and more that is the future, that is the current and the future of how buprenorphine is going to be delivered, is in primary care practices. And just get people on medication. Induction is really hard, as we're going to hear about later. And I think we have evidence that the first 30 days is the hardest, and starting at a higher dose and giving people a longer day supply can help them to be successful in this. Higher doses, there is some marginal benefit of higher doses. So I think in reviewing this data, I would be more kind of willing to increase a patient's dose at any hint of clinical instability. And we might have something to learn for doing more routine metabolite screening. And there's lots of new delivery mechanisms that I think are going to continue to evolve over the next several years, and maybe we'll have more forms and ways to offer this medication to patients. Thank you very much. And I'm open to questions.
There's one question, based on the data you looked at, would you recommend a change in the Washington State Medicaid limitation on number of days of films or tabs at the initial buprenorphine prescription?
Yeah, that's a really good question. I think that in order to say like this is best practice treatment, I would say we need more data. This was like retrospective insurance claims data, and they tried to filter by diagnosis, but sometimes like a chronic pain diagnosis could probably get mixed in there. And so, I mean, the best would be to do like a prospective study and adjust to be able to know that that's really helpful. But would I want to prescribe more than 7 days? Yeah, I would. So I think that we can't say like definitively 100%, but I do think it's worthwhile like seriously considering that limitation.
Another question. Do you have a recommendation about whether and when to do norbutyl metabolite testing?
Yeah, also a really good question. This study, the one from kind of the New York sample, made me think like certainly if someone's on a higher dose, and that could probably be justified insurance-wise, if someone's on higher than like the standard 16 milligram recommended dose, I would think about maybe doing it annually or doing it on some sort of like routine basis. And certainly for people that seem to be a little bit more erratic in their refills and kind of their timing of visits, it might be useful to help make sure that we're offering patients the support that they need.
Okay. Are providers using Sublocade?
I don't know of any providers using Sublocade. Yeah.
And for general family medicine clinics without trained nurses for helping with induction, how do you recommend doing those first 30 days of induction?
Yeah. We will hear much more about that from our speaker, Dr. Sullivan, who's going to talk to you all about induction.
Maybe one more question. Do you know how much more it costs to run metabolites versus the basic dip?
I don't know the cost. What I do know is that Medicaid We'll cover it if there has to be a clear indication for why you're doing testing. And it has to be a follow-up of a presumptive test. And I think they cover up to like 16 of these per year, as long as it's a follow-up of a presumptive test and you've described why you're doing it. So I think saying that someone is on higher than the routine dose could be a reason. Great. So now I would like to introduce Ben Davis, who's going to be talking about behavioral health interventions.